Let's just kick it off. We're going to start with part one, where we're going to discuss the situation, red flags, and how we might respond to the client who doesn't know anything about SSRIs and wasn't sure that they wanted to be on the medication. Do either of you want to jump in first?
I can start us off. I think like the first thing that strikes me about this is just, I think I've said this in like past sessions too, just like that I really value informed consent in these kinds of things. And the fact that they don't really know anything about SSRIs, that they're in this place of crisis and we're just like given this drug, that just strikes me as a big red flag and something where, I would really want to support my client in like getting that information either on their own or having a conversation with their psychiatrist about it.
Mhm.
Yeah, agreed. I 100% agree with you. And there isn't really anything in the synopsis that we're given about the symptoms that they're experiencing. We don't know if they're taking the SSRI for anxiety or if it's for depression or for panic, so I guess I would want more information about what the client is experiencing.
I think it does say depression. It doesn't say much
depression
beyond that.
Oh, for depression. There we are. Yes. Okay. But yeah, I think I would want more information into specifically what they're experiencing.
Mm-hmm.
So, the part that I agree with you, Aspen, around there seems to be a lack of at least psychoeducation, if not informed consent. So I think the sticky part is like, to your point, Erin, is how much I wouldn't want to give the client the wrong impression that I can diagnose by asking questions around symptoms. It might be one of those things where it's like, oh, okay, I feel like if I was presented with a scenario, the psychiatrist recommended this based on symptoms that you mentioned to her, him, or them. And I'd clarify that I'm not licensed to diagnose, but I can either share resources about how they might learn about SSRIs in particular, or if there are things that I've read that have been helpful, I might mention them by name. And then, so like kind of help with the psychoeducation. But I think the hard part for me would be when they ask it, what do you think about the situation and whether I should be on the medication or not, is how to gently kind of say that I'm not at liberty to give you that opinion. But I think maybe also to make oneself available to the psychiatrist if the client wants to say, hey, I can share with them what I'm seeing, or be a resource in terms of, kind of, so you have a treatment team. But I think it's how do you gently extricate yourself from being put in a position where we're seen as giving our opinions on what they should be taking. Does that make sense? Does that sound reasonable?
Yeah, I really appreciate you bringing in like that collaborative approach and like having that conversation with the psychiatrist, like forming that care team. One thing in what you said, I mean, I think we are licensed to diagnose, just to put that out there. I don't know if I would necessarily go that route in this situation, but like we can provide client diagnosis.
Does that depend on your license though? Like an LPCC can, I think. I'm not sure LMFT can, but maybe I just haven't done enough research on that.
I have provided diagnosis as like a trainee MFT.
Oh, interesting.
Yeah.
That's so interesting. Yeah.
Patient?
I thought that it was, I too thought that it was sort of out of our scope, but maybe not, perhaps not.
Yeah. Or I'm just doing something totally wrong here, but yeah.
So interesting. Aspen, did that include medication? Were you told that you could diagnose for the purpose of medication?
Not for the purpose of medication. Yeah.
That's what I mostly meant. But this is so helpful, this conversation, because now it's worth clarifying because I know for insurance, we can often write what we diagnose the conditions as, but where the line is specifically based on license or conditions, I'm not sure.
Got it. Yeah, that was the context for me. Offering a diagnosis was for insurance purposes.
I think that makes
So
sense.
maybe just a little miscommunication there. Yeah. So coming back, yeah, I think offering to like collaborate and yeah, I think the question that you asked around like how to communicate to the client, like I'm not at liberty to make this decision for you, to tell you what to do here. Like, yeah, I'm just like, how can we make that conversation as like spacious as possible to be like, yeah, I want to support you in like exploring this, and like I can't give you my opinion here.
Yeah, it is. It's such a quandary because it's like I really do feel for a client in crisis. This person is reaching out and wanting to alleviate their symptoms in any way possible, and not knowing anything about what they're sort of embarking on with this journey into SSRIs is also just it worries me for their well-being. And so yeah, I agree that a collaborative effort is is the right choice.
Awesome. Shall we move on? I feel like there's more to say, especially your point about crisis, Aaron. Like that makes it makes everything more acute in terms of potentially supporting the person. And I'm also mindful that we have another 2 questions to answer. How do you all feel? Are you good?
Yeah, I'm down to move on. I think, yeah, one note on that I'm thinking about here is just like, yeah, the importance of consent even in crisis, and that I think sometimes I think in the history of the field of like psychiatry and stuff, there's a lot of like, oh, well, they're in crisis, so they don't get to consent. So I just want to like, yeah, bring that up and just like,
Yeah.
from a kind of like disability justice mad pride perspective also.
Yeah, that's a good point. That is, yes. Thank you for bringing that into the discussion for sure.
And I feel down to move on to part 2. I just wanted to bring that little note.
No, yeah, but it does generate a lot of thoughts within me, but yeah, I think we should move on.
Yeah, same for me as well. I appreciate you voicing that. All right, well, maybe we'll come back. Jonalyn, you gave us a lot to talk about this week. All right. All right, let's do it. So for case 2, we're gonna talk about numbers 2 and 3. The side effects and adjustments for Sarah, and the collaborative treatment approach. So common side effects for SSRIs and how healthcare professionals can assist in managing these effects during the initial phase of treatment. Either of you want to kick it off?
So the startup side effects that she was experiencing, it says mild nausea and difficulty sleeping. However, after time, her body adapted. Yeah, the startup syndrome can be really hard for people when they're starting out on, I guess, yeah, on any medication. It sounds like am I reading this where they titrated her up to her full dose? Yeah, that's good. I think that, again, in the spirit of full transparency and consent, like, helping Sarah to understand the potential side effects for starting up the medication is super important. And I don't think, and speaking from my personal experience, this is true. I don't think that providers are always giving ample amounts of information about potential side effects for starting up. There's just such a limited amount of time in the medical model that a clinician will have with a patient. And it doesn't feel like they're giving sufficient amount of time. And so I think that's where us as clinicians can come in and really, explore side effects.
Yeah. There's also on page 103, they talk about the common SSRI side effects: headache, nausea, nervousness, diarrhea, insomnia, weight gain, and sexual dysfunction. All right, we're at 10 minutes. And there's something about side effects that I feel like normalizing it, to your whole point, I don't think they acknowledge that they're what they could be and psychologically prepare people. And there's probably room, maybe for us, if the psychiatrist doesn't do it, to normalize and not have that be a cause of stress, or like that something is more wrong now. Like something was already wrong. I tried to do something to fix it, and now like everything else is falling apart, whatever everything else might mean to a client. So I do think there's a lot around like supporting them through that process.
Yeah. Yes.
Yeah. Managing expectations.
Yeah, managing expectations.
I'm really feeling your comment, because it's like, just putting myself in the place of a client who is starting out an antidepressant and experiencing some unwanted side effects, is it almost amplifies their predicament, like it amplifies what's going on, that there's a reason why they got on these SSRIs in the first place, for a crisis, and it's not helping. And they're like, I just get there's like a sense of like, I just want to be okay,
Yeah.
Yeah.
Yeah, and how scary it can be when you think you're taking a step forward and it feels initially like a step back, or multiple step backs.
Yeah.
I was reading somewhere, I'm trying to find it, that like, I think it takes, so onset of clinical action for all antidepressants may take from 2 to 6 weeks. I'm on page 112. And then it said, there may be side effects. Oh no, sorry, looks like I read it wrong. I thought it was saying that the side effects might last 4 to 8 weeks, but it was saying the length of treatment varies with clients. It can take 4 to 8 weeks for symptoms to subside. So 2 to 6 weeks, 4 to 8 weeks. But that kind of, I guess, if the onset of side effects is kind of when your body's ramping, that's like almost 1 to 2 months of being like, can't sleep, nausea. At what point do you want to pull the plug and be like, I got to try something else?
Yeah. And I think that in that titration as well, it's like you may not start, it's not the kind of thing where it's like you pop like a benzo, like you're not going to pop an SSRI and then just immediately feel better. It needs a chance to get in your system, and to titrate up to the level of medication that you need to actually start feeling the effect. So it's like, when someone is not feeling okay immediately, and on the other side of that, experiencing negative side effects from the medication, I'm imagining that, yeah, there's such there may be a desire to just quit altogether.
Totally. Yeah, and I think another thing that's coming up for me in that is a lot of people don't know about like tapering off of SSRIs, and even when you're just starting off, like jumping off of it really quickly is like a decision that really should be made with a psychiatrist. So I think that's like another role in just like having these conversations with clients, just to like do those little pieces of psychoeducation and make sure that they're not making any like big decisions on their own. Also thinking for time, maybe we should move on to part 3.
Yeah.
Perfect. Yes.
Cool. So this is the collaborative treatment approach, highlighting the importance of an interdisciplinary approach, where counseling and pharmacological interventions complement each other. I think a lot of what we were talking about for the last one actually kind of applies here too. Like, yeah, that piece around managing expectations, like